right, we'll get started. Good evening, everyone, and welcome to the Together We Build Pediatric Services virtual town hall. This is the third in a series of conversations that will take place over the next few weeks, looking at 11 program-specific areas of planning for the new Windsor-Essex Acute Care Hospital. So before we begin tonight, let's respectfully acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Niswi, Ishkoden, Anishinaabe, the Three Fires Confederacy, Ojibwe, Ottawa, and Potawatomi. We acknowledge the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation. So on behalf of the project management team overseeing stage 2 planning for the new hospital, once again, we're pleased to welcome everyone joining us tonight via Zoom webinar. I'm Allison Johnson, Manager of Communications and Community Engagement for this project, and your moderator for tonight's conversation. Tonight, you will have the opportunity to meet some members of the user group designing the future pediatrics department. You'll have the opportunity to learn about the work that you're doing, and you'll have the opportunity to ask questions. So the Q&A portion will take place at the end of tonight's presentation, but you're welcome at any time to pose a question by clicking the Q&A button at the bottom of your screen and typing in your question. We will do our best to answer as many questions as possible, but please note the focus of this town hall is stage 2 planning of pediatric services. So this includes items related to the physical structure of the department, its layout, what other programs and services are located nearby the department, and design features or technologies. So basically, how can we design this facility so that it is patient and family friendly for our youngest patients? Now, to maintain the flow and focus of this conversation, please ensure that your questions are related to this topic. And following tonight's conversation, we also invite you to visit our engagement platform at togetherwebuild.wrh.on.ca, and we will put this in the chat section so you can just cut and paste it. And here you can ask any further questions. You can take our survey. There's one specifically related to pediatric services. You can share your ideas. And now I would like to introduce you to our panel guests for tonight. Everyone, please say hello to Rosemary Petrakis, Vice President of Women's and Children's Services, Deb Maya Parent, Director of Women's and Children's Services, Dr. Lena Morgan is Chief of Pediatrics, Faith Nesdoldi is a consultant with Agnew Peckham Healthcare Planning, and she's been working with the user group planning for the hospital, specifically in this area. Melissa Patrick is a patient representative working with the pediatrics team in this user group. Dr. Andrew Petrakis is Director of Clinical Services Planning for the project. And Paul Landry is Project Director for the new Windsor-Essex Acute Care Hospital project. So thank you everyone for being here with us tonight. Now, Paul, we've met him for the last 3 days. He has led several major hospital projects right across the country, and he's going to kick off our conversation today with a look at what exactly is involved in the planning process and specifically what's involved in stage 2 planning. Paul?
Thank you, Allison. Firstly, I would like to thank all of the community participants for taking the time to participate in this virtual town hall meeting with us. Your participation, your questions, and your input are very important to us as we move forward to plan this service, but indeed the entire hospital. I'd also like to say that how much it is an honor and a privilege for me to be a part of the planning of the new Windsor-Essex Acute Care Hospital. We're going to develop something amazing for this entire region. The first slide that I'd like to turn my attention to is a slide that outlines the, at a very high level, the 5 planning stages. The first one we've been through already and submitted back in 2015 and received approval from the Ministry of Health, along with some direction and some comments that to guide us in the work that we're in now in stage 2, which I will describe in a little more detail in the next slide. But essentially it's the development of what we're going to be talking about tonight, presenting to you. It's the development of a functional program that describes all of the services, the volumes, staffing levels, and a very detailed space list for this service, but also all of the clinical and non-clinical services in the new hospital. So we're effectively talking about a list of thousands of rooms that comprise the new hospital. By mid-June, we will have completed this functional program document. We'll be onboarding a team of architects and engineers to then work with our user groups to develop block schematic plans that should be completed by late fall. And the third part of the stage 2 submission will be a review of the cost estimate, which follows us through these stages until we get into construction, until we award a contract, of course. And so those three components, the functional program, the block schematics, and a refreshed cost estimate would be submitted to the Ministry of Health by next winter. Stage 3 is then moving further into the design and developing what we refer to as indicative schematic drawings. And so it's a much more detailed planning and design development. And the second part of stage 3 is the preparation of the procurement documents to take this project out into the marketplace. Stage 4 is selecting through a very detailed evaluation process the developer for this project. And the developer will include a constructor, and constructors, I should say, because there will be many construction companies involved in this, but one general contractor. And they will also bring architects and engineers to further our indicative design into the working drawings that are required to obviously construct a building of this nature. But most buildings, I think people would do that even for house plans. You'd get into detailed drawings before the contractor starts to construct the building. And so we will select that developer through the process in stage 4, and construction then would get underway in stage 5. So stage 5 is really the construction phase, and our scheduling, which is preliminary scheduling that is being worked on with the Ministry of Health and Infrastructure Ontario. If all goes well, especially in between these stages and the review processes by the ministry and government, we can move along this timeline that we think is reasonable, and get the shovel in the ground in the summer of 2026, with a completion time frame of the summer of 2030. The next slide then is simply a further breakdown of what I've described in stage 2, which is the functional program work that is underway now. And I should point out that we're really only approaching the midway point of that work. So we've had 2 rounds of meetings with approximately 40 user groups, clinical and non-clinical. We've reviewed a first draft of the document, so there's more work to be done. And in many of those user groups, we have 15 patients that have been onboarded into mostly clinical groups, but also one that we've named the public areas. And of course, it's very important for us to have that patient perspective when they actually approach the front doors and walk into the building, and we create intuitive wayfinding and really great signage so that people can find their way through this new hospital. The functional program will be a document then that we review and present to the architects that will be onboarded, as I mentioned, in June, and they will proceed to develop the block schematics with all of these user groups and a massing of the building itself. And that, of course, will then be presented to cost estimators that will review the cost estimate and update it, and all of that put together into a submission to the ministry early in 2023. So as I mentioned, it's early going, many months ahead of us, lots of time for patients to input and for the community to input their ideas and to pose questions to us so that hopefully we can respond to all of them and move forward together. Back to you, Allison.
Thanks, Paul. And again, further to what Paul was saying there, as you can see, it is really early on in the stage 2 planning. Windsor Regional Hospital, the user group teams hit the ground early this year and got to work. But we wanted to invite you into the conversation early so that, we can have this two-way conversation. You can let us know what is important from your perspective while we're planning, and we can answer any questions that we have. Again, please post your questions throughout. Because it's so early, we may not have all of the answers, not today, but we will answer them throughout. And again, your feedback is important as we move through this process. The first question of the night, once again, goes to Dr. Petrakis, who sits on most of the meetings, many meetings, and has his finger on the pulse of the planning that's been going on. First question of the night, Dr. Petrakis, how does planning for pediatrics fit into the bigger planning picture here?
Thanks, Allison, and good evening, everyone. I'd like to just reinforce a couple of comments made by Paul first. On behalf of all the functional groups, I would like to thank all of our community participants for being here tonight to share their comments, suggestions, and questions regarding planning of child services for our new hospital. And I just want to say that during every meeting, during functional planning and during our town halls, there's always something new or interesting that we learn that we hope to incorporate into the planning for our new hospital. So please make sure that you do provide comments and questions to us and anything you think is pertinent for our evaluation. As Paul said, there are 40 functional planning groups, each deciding upon distribution of services, space requirements, workloads, staff, specific to their departments. But there is interchange of information between all these groups to ensure that the requests or requirements are relayed appropriately to the appropriate groups. They have impact on all these areas. So there's a great interchange of information after each one of these sessions. The key intra and interdepartmental associations required include, when we talk about PEDS inpatients and outpatients, we talk about the PEDS clinics, surgical daycare. We talk about PEDS relationship to maternal newborn in the NICU. There's also important relationships between pediatrics and the emergency department, as well as the operating rooms, and in general, how easy it is to get from all of these departments to the pediatrics department, which is very important for both patients and for their families. We want to make this as easy and simple and as comfortable for these patients and families as possible. And as you can see, the department does not plan in isolation. Everyone is interdependent on each other to provide the best planning for our new hospital and for the pediatrics department. Thanks, Allison.
Thanks, Dr. Petrakis. Next question is for Rosemary. Rosemary, when you're at these planning tables, what is the pediatric team's vision for the future department and the design of this area?
So the vision is to provide a family-centered design that allows for an exceptional experience for the patients, for the family, and the caregivers. Our goal is to hear from everybody, from our patients, our parents, our loved one, caregivers, and staff. Tell us what design features we should consider when planning the new PEDS unit. You've met the team. You're going to learn about the process. What we need to know now are your ideas, your thoughts. We need your engagement in the process so we can incorporate your thoughts and suggestions and comments into the new design.
Thanks, Rosemary. And once again, we have put that link in the chat section there. So please, anytime, copy, paste that and have your say on our engagement website. Next question tonight is for Deb. Deb, what are some of the important considerations that your team has top of mind when working on this piece of the design of the new hospital?
I think one of the main things that we've learned so much from COVID and having to isolate our children. So one of the main things that we've considered and put a lot of thought into is some large private rooms for all of these kids, which includes their own private bathroom, lots of room for parents to be comfortable. So I think that's one of the main considerations we have. And going on what Dr. Petrak has said, we need to make sure we do a lot of outpatient work. So we need to make sure that our inpatient and our outpatient units are working together. Those are the same staff that work through both of those. So we have a lot of flow going through both those areas. So we need to make sure that both of those areas flow well together. And then there's always the obvious, which people are going to say, everything needs to be child friendly, family focused, child friendly. So that's like the main things that we're considering right now.
Thanks. And that leads into my next question for Dr. Morgan. Dr. Morgan has been in this role for 2 decades, and she's been practicing in the community for 30 years now. And Dr. Morgan, you told me before that you were part of the move to the current pediatrics department 17 years ago, I think, and that at that time, the department was retrofitted into a space to accommodate pediatrics. So how is this opportunity to start fresh, start from a clean slate, different than that previous move into an existing space?
Well, that it's very important because it gives us the opportunity to design things the way that we want them to be designed, instead of having to try and fit into something that's already designed. It's kind of like the difference between buying a house that somebody lived in before and trying to make the kitchen work, because it doesn't things might not be in the place, and you might think, gee, I really would rather have had the fridge over here or the stove over here. And we've had, I'd say, 17 years to look at the design that we have right now and say, this isn't working, or this is really working, and build our own new house and have it the state of the art that will accommodate all of our needs, both the needs for staff to make sure that the staff flow is good, and also for our learners, as well as for the patients and their families. Like, it's very, very important that we have a child-friendly space, but also a space that helps to accommodate their families and their needs as well, because it's very important that everybody who is attending to that child feels comfortable and safe, and feels that the space is functional for them and for the children.
And Rosemary, a question for you, because I think this is on a lot of people's minds. Where does the Ronald McDonald House fit into the planning for the new hospital?
So the Ronald McDonald House will be either in the hospital or adjacent to the hospital. Ronald McDonald is a key supporter of our patients and our families, and it's an integral part of our planning. I can think back, I was part of the initial team that brought Ronald McDonald House to Windsor Regional. And when we had those initial discussions, we talked about the future hospital. And right from the beginning, it was planned that Ronald McDonald would move with us. And we talked about, look how much money we're spending now to have it in the hospital. And we're going to re-spend that money or raise more money to have you move with us. And from Ronald McDonald, they said it would be timely, because it would be time for us to renovate. It would be time for us to add on. So they had no qualms about moving with us and financing it, because it is not funded by the Ministry of Health. And it is part of a different functional planning process than we have with pediatrics.
Thanks, Rosemary. But like you mentioned, such an integral part of the hospital, and nice to know that that will still be there for families moving forward. So next, we're going to hear from Faith Nesdoli. She's a consultant for Agnew Peckham, and Agnew Peckham, of course, has been part of some of the largest and most recent hospital builds across the country, including the Ottawa Hospital and Humber River Hospital, just to name a couple. And Faith has been working closely with the pediatrics team and is now going to talk about some of the work that they've done and some trends that her team is seeing in the area of pediatrics. Faith?
Great. Thank you very much, Allison. So again, like Paul, I'd like to say that I'm really happy to be on board working on this project. And I just want to say one brief thing. One of my very first projects as as a planner was when I was working at McMaster Children's Hospital. So back in the day, and that's where I really got excited about planning the pediatrics renovations there and a brand new NICU. So I've have a special place in my heart for pediatrics planning. So I'll just share my screen and I will take you through a few slides. Some of this material has, some of this material has been covered already by Paul, and so I'll go through it fairly quickly. But I do want to say at the outset, or just to remind everybody, because I know that when we get into design is much more exciting than some of the work that we're doing right now in functional programming. But form does follow function. That's why we have to get things down in words. I always, when people ask me what we do, I say, well, we write the words that the architects translate into design. So that's really in a nutshell what we're doing and what we're working through with the functional programming user groups right now. As you all know, there's been many changes to healthcare practices over time, and the planning that we do is driven by a lot of these changes. Most significantly, we've been influenced, as Deb alluded to, back in the early 2000s when SARS came into being, and now COVID has had a big impact on some of the approaches to the planning. One of the key things that we want to remember, though, is that we want to plan the building to be as flexible as possible, because we know that it might be another 50 or 60 years before we do get a new building. Okay, so stage 2 functional programming content. We are going to be writing about all the services at the new hospital, the flows, so how patients and visitors and staff and materials flow through the hospital, all the workload and staffing, the adjacencies of the departments, and the architects will put this together in terms of how the departments are located relative to one another. And then, as Paul mentioned, we do a detailed space list for every single program, service, and department in the hospital. So we'll be listing thousands and thousands of rooms. We are planning for 2 timeframes. Our first planning timeframe is around the time of opening, 28-29, and our second planning timeframe really is to 2038-39. And we're hoping that the ministry will allow some flexibility to provide for that second time frame, so that if there's growth in certain areas, that can be incorporated earlier. As Paul mentioned, the block schematic plans is what will be happening next, that the architects will be working on with the planning teams. Okay. So within each functional program, so for example, for pediatrics, we're doing 2 functional programs. We're doing one for the inpatient services, and we're doing another for the outpatient services with one team. So we're looking at both of those areas. So first of all, what services are we providing? So what kinds of inpatients will we have on the unit? Medical, surgical, oncology, palliative, for example, and then the types of clinics that we're providing in the outpatient areas. There's a section, the operational processes, and as I mentioned earlier, here we describe how everybody uses the space and flows through the department. We use a lot of diagrams to do this, and it's really just to describe how things work. Workload, so the current number of beds, the projected number of bed, the current number of the various types of clinic visits, and what is our projected number of those visits. And same for staffing. So in order to support the workload, how many staff do we need to do that? And then we get into the next section, which is the planning and design requirements. And in this section, we're talking about our key departmental agencies. So as Dr. Petrakis mentioned, surgery, critical care, the women's, the maternal and birthing program. So what are the key adjacencies for the pediatrics program? And then we get into the details about how we want the space organized. So how the bed area is organized, how the various support spaces are organized, and I'll show you some slides on that in a bit. And then we also do a, particularly for outpatient areas, we do some calculations to help the ministry understand how we determine the number of examination rooms, for example. And then, of course, finally, there's the space list, the detailed room by room list of all the spaces. Okay, in terms of some of the things that we're considering, or some of the trends in planning and things that are up top of mind for us as we're doing our planning, certainly is patient and family-centered care, and of course, also including being, child friendly. And how do we incorporate that into how we're planning and organizing the space? We are planning 100% private rooms. The ministry has recently, really probably more based on COVID than anything else, but they've shifted to agreeing that we can plan 100% private rooms. We plan the rooms so that every patient has a 3-piece bathroom within the room. So a sink, a toilet, and a shower or a tub. So there's a washroom in every room. Within the rooms, there's also family supports or a family zone. Infection prevention and control is top of mind right now. So we consider that with the work we're doing. For example, we'll have a number of bedrooms that are airborne isolation rooms for children with infectious diseases to have that specialized rooms. We want to make sure that we're planning the space to be operationally efficient, so that things are located where it's to reduce the number of steps for staff. Very important for pediatrics planning is planning for flexibility and surge capacity, because as you may know, we have our winter season where we have peaks of inpatient stays, for example. So how do we incorporate this within the number of bedrooms that we're allowed to plan by the ministry? So there are tricks by where you can plan a second head wall in a bedroom to put another patient in the room for a short period of time, for example. And finally, one thing that we've talked a lot about already with the team, but that we'll be focusing more on, is the location of the outpatient services in relation to the inpatient services, because there is a lot of staff crossover between the two areas. So we want to make sure that we plan for that as well. So I have included just a little bubble diagrams of our outpatient area and our inpatient area. And then, so basically just showing that, and this is just very, very high level, that in our outpatient area, we have a reception waiting area. And this is considered on stage. It's rooms that patients and families access. So we've got our exam treatment area and our surgical daycare. And then we have a staff entrance into our staff and administration areas. And of course, then they can easily go to the clinic areas as well. We're showing the pediatric unit close by. In the inpatient area, we have basically our communication center. This is our main hub of activity, and where many of nursing and other staff are doing some of their support work when they're not at the bedside. We have our pods of inpatient beds. And then we have various shared areas between the bedrooms. So we have special supports for patient and families. We have administrative and clinical support areas. So these are things like the soiled and the clean supply rooms that support the bedrooms. And then facilities for staff, like their staff lounges and locker areas. Whoa. Sorry. I don't know what happened.
There we are.
It's
Yeah,
back.
so we're back and I'm going down to, oh, maybe that was my last slide. That was my last slide. Sorry about that. Okay.
No problem. Thanks, Faith. So my next question, and we're going to bring Melissa into the conversation. Melissa is a patient rep who's been working with this user group since they started earlier this year. And Melissa, as a patient rep, you do bring an important lens to this conversation. I want to ask what considerations are most important for you when you're at this table and why?
Hi, Allison. Thank you and welcome everyone. So in 2018, our daughter was diagnosed with leukemia. And over the course of her 2.5 years of treatment, I spent months sleeping in hospitals. And on those sleepless nights, I would lay awake and wonder, how could they do things differently in these hospitals to make them more kid and family friendly? Fast forward 3 years, and here we are. This is our chance to make this hospital the best it can be. And I hope you have a lot of questions, because I have a lot of questions and considerations. Like, where will the pediatric floor be located? How will it be accessed? Will there just be one elevator rather than the two like you take at Windsor Regional now? Or will there be an outdoors entry so the kids don't have to go through the hospital? There'll be a POGO clinic. Will the POGO clinic have a separate entrance? Will there be additional procedures for oncology, additional treatments for treatment procedures for oncology kids, for example, like LP procedures, so our oncology families don't have to drive to London for treatment? Will there be more pediatric oncologists on staff? And what other programs will operate from the pediatric floor? Will there be more programs and specialists so local families don't have to drive to Windsor or be transferred or driven to London to receive care? Will the design be kid-friendly? Nobody wants to go to the hospital. Hospitals are scary. Windsor Regional has some awesome kid-friendly features like the slushy machines and the animals on the roof. Will there be creative features incorporated into the design? I have so many questions, and I'm so excited to hear what you have to say.
Thank you, Melissa. And again, thank you for the time that you spend working with this group and making sure that all of these questions are out there. I do encourage everyone who has these questions and similar questions and ideas to visit the engagement site. There is a spot where you can post these suggestions and you can comment on each other's and get that conversation going. But before we move on, I want to ask you, Melissa, what is it like to be part of this planning process, and how have you found it? Because I know you come in with all these ideas and now you're seeing how they're actually put into play, and I just want to know what that's like.
Hi, yeah. So I'm not a doctor, I'm not a nurse, I'm not staff, so I don't know the flow of the hospitals, but I do know what it's like to sleep on a chair next to your child's bed, you know, when they're sick and you're scared and you don't know, and you just want the best for them, and you know, that family friendly, fun environment. And this process has been so interesting. And I'm so proud of the pediatric group that I've been involved with. Everyone is bringing their best suggestions and ideas to the meeting. It's really early in the process, but I'm excited to see the ideas come to life because everyone is so passionate about this project. They want it to be just absolutely the best it can be. And it's really exciting to see. So thank you.
Thank you. That's one of the things that I think is cool too. When I joined some of these user groups, you said, I'm not a doctor, I'm not, but you know, everybody at this table brings a different perspective to it, right? There's also expert planners at this table and people from different backgrounds. And I do think that it makes for a really interesting conversation. So thank you. So I think with that, we will move on to some questions now. Again, if you do have further questions tonight, please put them in the Q&A section. If we don't get to all the questions tonight, again, visit the Together We Build engagement site, togetherwebuild.on.ca, where you can continue this conversation. So let's start with a question from Cynthia tonight. Cynthia wants to know, will there be an actual pediatric emergency room separate from the adult emergency room? And I'm going to direct this one to Dr. Petrakis because he, again, is involved in many of the different groups, including the emergency department. Dr. Petrakis?
Great question, Cynthia. We're currently planning for an area that will deal with pediatric emergencies. The discussion really revolves around, should this be part of the actual emergency department or should it be separate from the emergency department? We're currently working our way through this. This will all depend on comparing our data, our current volumes and our projected volumes with other hospitals that are in the same situation that we are, that experience the same volumes. So this is still under consideration, but I think you can safely bet on having an area specifically for peds that's family friendly, that will encourage families to be there with their loved ones, and there'll be separate waiting areas for the pediatric area and make it entirely family friendly.
Thanks, Dr. Petrakis. And while I have you here, I've got another question for you. This one's from Lucy. Lucy wants to know, will the new hospital have a CT machine that is collaborated for children?
Another great question. There are CT machines that are made especially for pediatrics. They're on obviously a much smaller scale. This is something that will have to be discussed between pediatrics and diagnostic imaging. We have to ensure that we have sufficient volumes to promote this particular type of equipment in our new department.
Thank you. So this next question comes from Tracy, and I'm going to direct it to Deb because you mentioned this, but also I would like to hear from Faith as well. When we talk about, will you be planning space for parents to sleep at the bedside in the pediatric unit? And also, what would that look like?
Yeah, so I think I'll go first here, Faith. So all of the pediatric rooms are going to be private rooms. They're all going to be spacious rooms. They're all going to be family friendly so that parents are comfortable when they're staying overnight with their children. We obviously encourage families to be by the bedside because every child wants their parents. Nobody wants to be alone in the hospital. So we are making sure that all these rooms are set up so that the families feel comfortable and safe with their children in the hospital.
So I'll just add to that. Certainly, we would normally see a day bed or more of a single bed in an inpatient bedroom. So place for one parent, but probably not for both.
And is that like sorry if you've already mentioned that, but is it a pull down or what do these typically look like?
There's various different models, and Paul might want to add something too on this, but there's different models. So it could be something that's called a day bed that lies flat, or pull down, but more commonly, I think we would call them a day bed.
Yeah, perhaps I could add a bit to that, Faith. I've seen some really excellent models that are like a day bed. They actually serve as a flat couch, with cushions, during the day where you can have, perhaps several people, visiting the patient, and then convert very easily at nighttime for, one of the parents, to sleep over, with the child. And we're not quite there yet, but, you obviously have to fit a component like that carefully into the room. We will get to the design of the room, but probably more in stage 3. This stage is about making sure that we're sizing the room in line with, growths in rooms because of various equipment that needs to be placed in a room for different types of situations or cases of patients. So we'll work through that design in that stage 3. I think, another important issue in a patient room is that window and the ability for the patient to be able to look outside. And depending on what level look to the distance and can see nature, and these are important details in the design of a room, the ultimate patient room, and that's really what we're focused on developing here for the new hospital.
Thanks, Paul. We have a question here. Part of this was already answered. What percentage of the rooms will be private versus semi-private? But Tracy also would like to know, will you have a closed observation space? Deb or Faith?
Sure, I can answer that. Yes, absolutely is the easy short answer for that. There will be rooms that are close for observation, close to the nursing station, so that the staff have easy access to those patients. Absolutely. Yeah.
Thank you. A question for Dr. Morgan. Will there be pediatric and teen mental health?
I will say that we haven't talked too much about that yet in our functional planning. As of right now, the plans were, as far as I know, to maintain mental health all in one spot, not necessarily at the acute care hospital. We still have to look. We still have to have some considerations to make regarding that, because I will tell you, historically, there was a time when adolescent mental health beds were actually adjacent to or within the pediatric floor. And there were a lot of issues with that, concerns about the safety of some of our younger patients, or exposure of some of those younger patients to some of the behavioral problems of those adolescent patients, which is why those beds were actually moved off site and not attached directly to pediatrics. So there does still need to be some consideration in that, and certainly we need to have further consultation with our psychiatric colleagues as well regarding where those beds will be located. That I don't think that decision has actually been finalized yet.
And again, that's a common theme in the planning, that we haven't made all of the decisions yet, but that will remain, and please continue to ask. Another question,
Allison, before you go.
I'm sorry.
I had my hand up.
You did, I'm sorry, I didn't see that.
Okay, no, I just wanted to add, in the emergency department, though, there will be a specialized area for mental health assessment. So it is not that we're not going to be assessing these patients because mental health has been assigned to Hotel Dieu Grace Hospital. There will be, as I said, areas within the emergency department that will specialize in assessing and managing acute mental health problems.
Okay, thank you for that. And well, I have you here. Will there be a pediatric ICU separate from the adult ICU?
Another great question. I see Dr. Morgan smiling right at the moment. There's been a lot of discussion about this. It currently is still under discussion. In order to have a specialized ICU for pediatrics, there has to be the volume to support staff, not only the nursing staff, but the medical staff to man these units. At the current time, that's just not the case. And as I said, there's further planning involved with this.
Dr. Morgan, I see your hand is up now.
I put my hand up directly. I just would add to what Dr. Petrakis has said in that I guess that there's a little link between the question about the pediatric emergency department and the pediatric intensive care unit. Our vision, and from the Department of Pediatrics, is for us to have definitely more specialized care available for pediatric emergency in the pediatric emergency room, with more physicians there who are either dedicated completely to the care of pediatric patients, or who have more specialized training in caring for the pediatric patients. And that it would give us a better ability to stabilize those patients, even if we're not able to keep them in the intensive care unit here. When he's talking about volumes, really it comes down to, if you have one patient a month in in an intensive care unit, it would be next to impossible for you to have a physician who's dedicated solely to taking care of that one patient, a month in an ICU. So it's still on the wish list, and we still do have to look at our volumes and see if that's something that might be possible in the future. We are looking at finding ways to make sure that there's more expertise specific to pediatrics that are available, at least for the urgent and emergent care of pediatric patients that we now presently have to send out of the city, or more expertise in stabilizing those patients prior to having to send them outside the city. And I guess also included in that is that the site of the new hospital is very fortuitous, because it will give us the ability to have a helipad and easy access to air transport for patients who do need to be transferred out, and will make it much easier and smoother for patients who do need to be transported out of the city if we don't have a dedicated pediatric ICU.
Great.
Dr. Morgan's department really is staffed really quite well. I believe from our previous conversations, there are about 30 to 40 pediatricians now, general pediatricians in your department and in the city. That's what I understand. And they're more than anxious to provide that particular service in the emergency department when it becomes available.
Nice. A question for Faith. This one's from Natalie, and she wants to know, will there be a sensory room on the pediatric unit? And Faith, maybe you can also, for some of the others on here, just talk about what a sensory room is.
So sometimes the sensory room is called by its, there's a brand, it was developed originally a particular brand, and it's called a Snoozlin Room. And so it's a room that children can go into. It's multisensory. So there are some things that are would stimulate the child in terms of lighting, but it would also have a calming effect too. So there's different aspects to it that could be switched on or off, or be utilized in the room. And it's basically more as a calming environment. And we haven't talked about it too much to date, but I think the plan would be that it could definitely be included. It's not uncommon to include these spaces within other pediatric units. So it's certainly something that we're going to be discussing at our next user group meeting.
Great. And on a similar note, will there be more playrooms and dedicated spaces for siblings of patients?
So again, we're just starting to talk about the specialized spaces. But we do have something in the program now. But in terms of how much and how much accommodations we'll have for siblings, I think that's yet to be worked through with the team.
All right, thank you. A great question here from Anthony. Based on today's news of the massive investment in the city that could potentially spark growth, will we revisit our long-term patient projections for both peds and for adults? And I'd like to direct that question to Paul.
Well, thank you, Allison, and thank you, James, for really an excellent question. And I just want to pick up on some of what Faith shared with us in her presentation about, forecasting volumes and needs, out to 10 years and then beyond that to 20 years. So obviously the 10 years is what we're going to be building. So we want to have sufficient capacity on opening day for what we've forecasted for patient volumes moving through, all of our clinical services. The following 10 years, that the time frame of 2038-39 is really the tricky piece. And I'm very encouraged with the ministry's recent responses to new hospitals that are being planned in the province. And there is a clear expectation that we should be shelling in some space. So if you can imagine a building that has obviously multiple floors of inpatient units, and of course we're discussing something that's in sort of the range of at least 600 beds, but probably we're looking at the capacity for an increase over our current beds of in the range of 15 to 20%, which is a pretty significant increase towards the future. And we will be expected, which is a good thing, not a wish and we would like, but we are now expected to shell in an entire floor of inpatient unit, 2 inpatient units that would represent approximately 72 beds, so that we would have the surge capacity to respond to emergent needs, perhaps that outstrip some of our forecasts, or possibly, we hope not, but a pandemic that comes ashore again and we have to surge. We would be able to convert that space very quickly because we'd have all of the mechanical and electrical systems to fit that space out very quickly and grow into those beds in a very short period of time, as compared to trying to build an additional floor on top of the building, which is like impossible to do. But also, I should say that when it comes to looking at flex capacity and growth across other departments in the hospital, when we're working with the architects, we have to do what we call future-proof the master plan. And so we have to look at areas that are really critical and very difficult to expand, such as something like the OR or the emergency department or diagnostic imaging. And we have to intentionally place softer space, offices, storage, conference rooms, things of that nature, that we could remove, relocate to another area, and we could expand those very hard to expand areas like the ones that I've just mentioned. So we are through this planning process, and when we work with the architects to develop the block schematics, and then subsequently in stage 3, the indicative schematic designs, are really going to be looking at how we organize this building so that we have maximum flexibility to incorporate growth into the future.
Thanks, Paul. And that really is an interesting question at any time, really, but especially today, considering today's news.
Mm-hmm. Absolutely.
A question from Tracy, this one to Dr. Morgan. Are there populations that will be new or repatriated from other centers? And for example, Tracy says child and adolescent health separate from adult mental health or pediatrics.
I think we already talked a little bit about that with regard to adolescent and mental health, without that it hasn't really been decided yet as to whether or not those beds would be relocated to us or would remain with the other mental health facility. We still have to have some discussions about that and what would be best for that population. But best for that population as well as for the other children they would be interacting with on a pediatric floor. I'm not sure what other populations we'd be talking about, because those are the only pediatric populations that are located off site right now from us.
I think about with the new hospital as a recruitment tool. So with the new hospital within the 10 years, when we're recruiting both adult and pediatric specialists, will we see new ones coming to the hospital because of it? I know in the adult world, both in anesthesia and internal medicine, the new recruits that have come specifically because of the excitement of the new hospital. So there is new pediatricians with pediatric specialists coming. Do you see any others down the line coming, Dr. Morgan or Andrew?
Oh, I mean, I can answer that in the sense that we have expanded the number of subspecialists that we have in the city extremely over just even the past 10 years. When I first started here, we had no subspecialty representation within the city. We had none. Everybody who needed subspecialty care would have to go to London. Now we have a pediatric neurologist and a gastroenterologist and an endocrinologist and allergist and allergy and immunology. And, we're looking to expand that further and looking into the possibility of a pediatric cardiologist, hopefully eventually, and maybe a nephrologist, down the road. So Rosemary is right in the sense that if you build it, they will come, right? So we're hoping that if we build a hospital, that we'll be able to accommodate these people and make them feel like that they have, a good state-of-the-art space to work within, that they will be more enticed to come and practice here. But we've already had a number who have come to practice here. And yes, we are hoping that we will be able to expand the subspecialty services that we provide locally. I mean, even with hematology oncology, we have a full-time, hematologist oncologist. And although he works very closely still with London, we may be able to expand the potential services that we can provide locally to children that still have to travel to London down the road.
And Allison, we're in active discussions right now with the pediatric ophthalmologist. So hopefully within the year, when she's finished her training, she's gone to the States to get more training, that's a possibility of coming to our city.
Nice. And
Allison?
Yes.
Sorry, Allison, my hand's up again. I'm gonna have to get a bigger hand. Maybe I put both up.
one that like smacks me on the head would be good.
A big rubber thing, It not only applies to the subspecialists, but it's the medical school that generates the subspecialists eventually. Our medical school will be expanding. We currently have 38 medical students per year at the Windsor campus. We're going to be expanding shortly to 50 medical students per year. And once they get the flavor and they get to know our region, we've had many of the medical students who stay and continue on with the residency program in family practice and set up family practices here in Essex County. The chief of staff out at Leamington, who has gone on to better things now in Leamington, was once one of our students. There's always a potential for adding new subspecialists, family medicine residents, family medicine practitioners, once they have experience in our area.
And that's one of the themes that has come up like repeatedly through all three so far. And I know when we're having these conversations, and it's really exciting to just hear about how this information is hitting other people and the impact that could have that we don't even know about yet.
And I think, Allison, too, with the new hospital, we're developing a research center. So we're just in the infancy of our research and developing our whole research program, but in the new hospital, I don't know, Paul, if you want to say anything more about the research and the research center that we're planning.
Well, thank you, Rosemary. That's a good lead in. Since my arrival in early January, David Mouche put me in contact with representatives of the university to begin the discussions of a health innovation park that would include an education research center. And so we are forming planning teams to start to develop the program for what that could look like. And of course, it will follow a very similar path to the planning of the hospital, which is really, really great in terms of, a partnership, hopefully between the hospital and the university to advance, health-related research in Windsor. And so there are multiple components of what are possible in that health innovation park, and we'll be able to share more information about what that looks like in the coming months. But fortunately, we have a very nice big site that we can develop a campus on for both the hospital and a research center. There's also been some, of course, as many of you know, discussions of a simulation, training center, a SIMS center. And of course, we have a large number of nursing students from the university, and you can just imagine what that kind of a facility would, how we would benefit from that in terms of our education programming as well. People that are familiar with these sim centers, and actually even human robots that students can learn on. So we're quite excited about moving forward with the planning of that potential component as well.
And I think that everyone's starting to hear all of the excitement that we've been hearing for like the conversations that have been happening this year. When you think about what that means for our future and really how transformative this opportunity is for the hospital and for the community and healthcare in the community. And I'm glad that everybody had the opportunity to participate in this conversation with us. And I think that this is a good note to end the conversation on today. I do have one more question for Melissa, because I've been watching you through all of this and your facial expressions, and how different is the hospital that we're starting to talk about today? How different is that from the one that you experience?
Hospital we're talking about today is just, it's very exciting to me. I feel like everyone is getting a voice to be able to put their input into it. Like I said, I'm not a doctor, I'm not a nurse, I'm not running an 8-hour shift. I'm the mom who was next to a little one who was deathly ill. And, you know, you at 8, 9 o'clock at night, you look over and you see your Subway sub that you didn't finish at lunchtime, and it's warm because there's no fridge in your room to keep it cold. So I want to see input. I want to walk in and I want to see kids' eyes like just be amazed by the design on the walls. I want them to be excited to go into the hospital, not scared. I know I've taken Megan and I said, you know, we got to go to the hospital. And she'll be on the floor crying because she knows what she's going for. She knows she's going to get accessed or she's going to get her chemo, and she's a puddle, and I'll say, hey, you know what? We can get a slushie after. And that's what got her through that day. And that's what got through that treatment. And I'm so excited that, you know, we're just being given this opportunity to say, hey, let's make this the best we can absolutely do it. Let's do this. Let's do this for the kids. Let's do this for the community. And let's just make this so easy for the kids, for the parents, and make it feel like you're at home when you have to be stuck in a hospital. I'm excited to see it.
Thank you very much. Thank you for your involvement. And thank you to everybody who joined us tonight. This was a really great conversation. There are still a few questions, very few that we didn't address yet, but most of them look like they are similar to ones that we've already addressed. If there's anything that you didn't get answered tonight that you still want to, please visit our website again, togetherwebuild.wrh.on.ca. Continue this conversation, post your ideas, ask your questions, and really take a look at some of the other areas of planning that are happening in the hospital. The conversation doesn't end tonight. So this site that I've been pushing all night, this will remain live for at least 1 month after these town halls. You can continue to share your thoughts following that. And the results will be summarized and they'll be shared with our planning teams. As Paul mentioned, we're bringing the architects on board in the summer. We'll have that information ready to share with them, and your input will help guide the decision-making throughout the project. Please take the time to participate. And then later this year, in the fall, we will do this all again. You'll have a chance to join us again for a series of conversations, see how the planning has progressed, see how this input has been used, talk to some of the people who are on board with us at that point. So a lot to look forward to, and your voice really does matter here. So I want to thank all of you for taking the time to be here with us tonight. Again, once in a lifetime opportunity for healthcare, for hospital services in the region. And we're really happy to have you with us as we move through the stages. I hope you'll join us tomorrow, same time, same place. As I've been saying, tomorrow we're going to discuss the future of birthing and the neonatal intensive care unit. So please join us for that. A huge thank you to our panelists again tonight for your time this evening, all the work that you're doing in the user groups, and the work that you do every day for patients in Windsor, Essex. And for the final word of the night, I did promise Dr. Morgan she would have the last word tonight. So Dr. Morgan, over to you.
Thank you, Allison. I just, again, want to thank everybody who has joined us this evening and give some input. I know that we may not have answered all of your questions, but we have definitely had an opportunity to look at the things that you're suggesting and recommendations and ideas. And we want all that input so that we can develop the best program that we can and to be sure that our community is serviced um, as well as we possibly can, and keep people local when we can, and to make sure that the hospital is a fun and friendly environment. I guess that's a little bit of an exaggeration, but we do want it to be an environment where kids aren't afraid to come, that their families feel safe and secure and well supported. And we can only do that if we get as much input as we can from the community. And we want you to share your ideas so that we can build the best hospital that we can to service our community for years to come. Thank you.
Thanks, Dr. Morgan. Thanks, everybody. Good night.
Thanks.
Night.
Good night, everyone.
Good night.